Welcome, everyone. You've joined the University of Toronto Citywide Geriatric Medicine Grand Rounds and the 2025 Dr. Rory Fisher Lecture. To open our session, I would like to acknowledge the land on which we work, study, and live. The University of Toronto operates on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Wendat peoples. This territory is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples. We are grateful for the opportunity to work in this community and on this important traditional territory. As a virtual meeting, many of you are joining from different communities, and I invite you to take a moment to reflect on the traditional land that you are on right now and its original peoples. As we acknowledge the land, we also need to reflect on our personal relationship to it. Many of you, like myself, are settlers here and arrived here through different paths and family journeys. Land acknowledgements are only a starting point for larger, meaningful conversations, and I ask that you reflect on actions that you can take personally and in your daily life in our work together as part of your commitment to reconciliation. Today's Grand Rounds is the 2025 Dr. Rory Fisher Lecture. This lectureship was established by the Regional Geriatric Program of Toronto in 2016 to honor Dr. Fisher's leadership and pioneering work in geriatrics. I'd like to share just a few words about Dr. Fisher. Dr. Fisher was recruited to Sunnybrook Hospital in 1971 as its first geriatrician, and he quickly established an impressive array of geriatric services, including the first geriatric day hospital in Ontario, only the second day hospital in all of Canada. As an academic leader, Dr. Fisher had a number of firsts to his credit, being the first University of Toronto Program Director of Postgraduate Geriatric Medicine Training, the first Departmental Division Director for Geriatrics, the first head of the Interdepartmental Division of Geriatrics. He was a mentor to many of the most recognized names in geriatric medicine in Canada, and his outstanding contributions were recognized with numerous awards, including the Distinguished Service Award from the Canadian Geriatric Society, the Queen Elizabeth II Diamond Jubilee Medal, and the Order of Ontario. In January of 2024, our community lost a pioneer of Canadian geriatrics. He was a visionary and dedicated leader and a gentleman in every sense of the word. So to deliver this year's Dr. Rory Fisher Lecture, it's my pleasure to introduce Dr. Haesun Moon, who's joining us from Beijing on her international tour. Dr. Moon is a communication scientist, author, and educator whose work explores how conversations shape change. She is the creator of the Dialogue Orientation Quadrant and the concept of Interfluence, both widely used frameworks for making the work of coaching and therapy visible, measurable, and meaningful. As the executive director of the Canadian Centre for Brief Coaching and founder of the Human Learning Institute, Haesun leads programs grounded in practical research and real-world evidence. Her work integrates microanalysis, solution-focused practices, pedagogy to support learning and leadership in diverse settings, from schools and hospitals to boardrooms and communities. She's known for her warmth, clarity, and ability to turn complex ideas into accessible tools. Her latest book, Coaching A to Z, reflects her signature style of using ordinary words to spark extraordinary conversations. I know you're really going to enjoy the next hour we have with Haesun, and she's going to be talking to us about interfluence between what's said and what's heard. Thanks so much, Dr. Moon.
Wow, thank you so much for that. And all of you, I'm joining you from Beijing, and it's 1 o'clock in the morning. So I napped, don't worry, it's okay, I'm not overworking. But I managed to actually have laryngitis on the way here. So I'm here on a teaching tour, but I didn't have a voice for 4 days. So if you can imagine on a teaching tour with no voice. So today is actually the first day back that I have my voice. So I'm so glad that I have my voice back. So good to see many of you. My goodness, I was so nervous that I might not have my voice back. So here we go. Today's conversation is a topic that's really dear to me, just because I have a mother who is that age who actually has a geriatric specialist. And I am so fortunate in Toronto. And I'm so fortunate that she didn't know what to make of that she's at that age and all those things. And And she, after the very, very first appointment, on our ride back to our home, she said, "It's so weird. That doctor makes me feel like I am her aunt or something." And that really stayed with me because what did she do to make her feel that way? So I really care about this topic of interfluence, which is pretty much saying, how do we story each other? So today's topic is interfluence between what's said and what's heard. And also today's my first day that I am teaching with a candy in my mouth. So please bear with me as I have candy in my mouth. And there's no conflict of interest that's included or related to the content of this presentation. In case you're wondering, I will not tell you what candy I am eating or the tea that I'm drinking, and so on and so forth. So as a researcher, I want to do a little experiment with many of you. So you have a chat box. If you want to use a chat box feature, by the way, to put in the chat box where you're joining from, maybe a hospital or a clinic that you're part of, and where you're joining from. By the way, it's been so interesting because of my laryngitis. I went to probably like 3 different clinics in Korea and here and so on. And every time I watch what they do, and I actually listen to what they actually, how they talk as well. So there are people like me watching all the clinicians as they do their thing. Anyway, so good to see you joining from many different places. Look at that. Okay. So welcome everyone. And as a researcher, I want to do a baseline study. And this is probably one of those very few groups in the world that I don't have to explain what I mean by baseline. So you know what I mean by baseline. So here's a baseline, and I actually included a completely non-medical sort of transcript to begin with, but we're going to come back to a little bit more clinical narrative later on. But here is an example of something that somebody might say to you. And just my curiosity right now as a baseline is, how might you respond to this narrative? Let's say somebody comes to you and they say, could be a friend, could be a family, could be your colleague. They say, "Oh, I've been doing this work for a long time. And I used to feel like I was making a real impact. Lately, though, it's different. Meetings, metrics, constant changes. There's barely time to think, let alone connect with people the way I used to. I see things that needs to change, but it feels like pushing against the wall. And honestly, I'm not even sure if I'm still the right person for this. So maybe I've been here just too long." Now, when you hear something like this, what's your immediate response? Like, what would you like to say to this person? It's your turn to speak. They just finished their talk, and they look at you, and Susan says, "I feel you." Okay. So Brittany, what would you say to validate their feelings? What would you actually say in your response? Feel free to put in the chat box. It could be your friend. Maybe it's different if it's a friend. Maybe it's different if it's a colleague. And it sounds like feeling like you are making an impact that's important to you, okay? I feel like you may be describing burnout. Does that resonate with you? Okay. Okay. What else? What else would you say? And it's interesting to notice some of the words that you're adding, some of the words that you're preserving from what this person says. Ariel says, "Oh gosh, that's hard." Hmm? After the validation, maybe what would make things better, do you think? And what would you feel, or what would you like to feel instead? What makes you feel this way? Oh, these are so interesting. Give me a couple more. What would you like to say in your response? Maybe this is over dinner as you're barbecuing. Somebody says this. And then what do you say? Okay. Thank you. This is really interesting. Oh, I love Lorna says, tell me more. Oh, this tell me more is an interesting thing because it can serve different purposes. Tell me more could be yes, tell me more. Or sometimes when we don't know what to say, we're like, yeah, tell me more. We're gonna buy some time too. When you have a good day, what makes it a good day for you? Okay, this is really important data that I'm collecting. Thank you so much for doing this. So this is the baseline. Now we're gonna come back to this narrative, but I want to tell you a couple or three different stories about research. I love telling research stories. I think that's like the best bedtime stories. I don't know about you, but I love research stories. And some of these stories are about when the story outruns the data. So story number one, many of you might know this story actually. So story number one comes from a case, what my care look like, and very well-known study in a clinical setting where in one case, I think this was actually in an emergency setting, emergency room, where to begin with, there's not enough chairs, right? But then usually there's in an emergency room, there's a patient and maybe one or two, or even sometimes more family members. Nowadays, we only allow one person. But when they used to have like more family members in the room and so on. Now we study the physicians, in this case was resident doctors, and they looked at their behaviors. And sometimes they were instructed, and especially in this case, there were some natural observations too. But in this particular case, they made experimental design where doctors will go in and experimental design number one, the doctors are talking to the patient and their families while sitting down. And second case or second experimental design, second condition is when the doctors are standing up. Sometimes they're standing up right by the door and they're just standing with their, clipboard and things like that. They're standing and talking to the patients. And all they do is simply they talk to the patients as they normally do, and then they both leave the room. How many of you know this study? Just give me like, I don't know, emojis or something if you know the study. And really the only difference would be, and not, there are many other variables, but here the main variable is the doctor standing or sitting. And then after they leave the room, researchers will go in the room. Not only the researchers are going in the room, but they're actually measuring the actual time that the physician is in the room, in the room, consultation room with a patient. And then after physicians leave the room, they go into the room and ask the patient and the families. And they ask them, how long do you think the doctor was here for? How many minutes do you think that they spent with you? So they already have the data about actual time spent, but also they're asking the patients about how they perceived the duration of time that they spent. As you can imagine, in which case do you think patients rated the duration to be longer, sitting or standing condition? What do you think? Brittany says sitting. Yeah? I don't know how to say your name, Yatusa. Okay, Paige, sitting. So many of you are guessing sitting condition. And how come? How come they might perceive this to be longer? And that was the case, actually. Patients, they rated the sitting condition to be, in some cases, a lot longer, much longer. So then they are measuring perception of care, objective behavior measures such as sitting, standing, and also how many minutes that they have spent. Not only that, other objective behavior measures included follow-up sessions. Are they more likely to follow the prescription, or are they more likely to follow through? Are they more likely to come back for a visit to check up? And not only that, over time, after about 6 months, they actually survey the patients again. How would you rate your experience in that emergency room? And their perception of care changed over time. It's amazing. Their perception of care changed over time. People who actually had a doctor sitting with them, their perception of care, it went up. They actually remembered it to be much better than they actually initially rated. Again, the doctors who are standing, their patients, their perception eroded over time. They remember that interaction as doctor was in and out. They didn't really care. And it directly influenced their quality of care that they rated. So patient experience was directly related to it's a simple thing, sitting or standing. Isn't that amazing? This study was called To Sit or Not to Sit. I think it's pretty clever. One of the classic studies to study what does our gesture do, even before we open our mouth. How we actually story our experience, does that actually have a clinical outcome differences? Absolutely, it does. Psychological, emotional measure, they also measured empathy. So how would you rate the doctor's empathy? So this will be a very interesting study for you to just read through. And it shows a stark difference between simple sitting and standing, and especially over time, how patients' experience of care changed. And also it's directly related to how they trust the clinician. You know that without trust, clinical outcome will suffer. And I did have that experience, unfortunately, with one of the doctors for oncologist for my dad. Over time, she was a very well-known doctor. Over time, she kept on doing some things that eroded our trust. So it was such a painful experience. And you know what it's like. You know, many of you are probably in practice, but also you are also a patient and you know what it's like to go see somebody. And that trust, without having that trust, the outcome will suffer. Isn't that interesting? Now, many of the things that I'm going to show you here, please read them because you're going to really enjoy, after hearing the story, reading the research becomes really fun. So that's a story number one. And hopefully you're thinking, what can I do in my practice to incorporate some of these things? But here's case number two. By the way, hopefully this is useful for you because I love doing this research and research stories. Case number two is what my care sound like. What do you sound like when you are expressing care? So here's an example of one of my favorite studies come from this particular one. And this was done in, I think, Philadelphia, in an outpatient clinic. And well, the clinic probably doesn't look like that, but you know, here's a photo of a clinic. And what my carers sound like, one of my favorite studies that I always talk about. So again, experimental design condition. So here's a neutral condition. So nothing is done to that condition. Design number one, condition number one. Physicians are sitting down with the patient and they will end their consultation with one sentence. That's different than condition number two. So here's a context. Patients walk into this outpatient clinic, much like walk-in clinic, I would say. So you go to a walk-in clinic. And usually patients sit there and they wait. And then while they wait, researchers actually give them a questionnaire to fill out. And I think this is what we do here too in Canada, that you fill out a questionnaire about what are you here to, you know, the history and all of that. And then also, what are you here to talk about? You know, what are some major issues, minor issues, concerns that you have? Wow, this laryngitis is real. And as you actually fill out the form, you will actually say, you know, I'm here to talk to the doctor about this main concern and maybe some minor concerns. and then you give it back to the reception. After that, you're going to see the doctor. And then after the consultation, you're going to come out. And you are interviewed briefly about, so these were the concerns that you said you wanted to talk to the doctor about. Which one did you end up telling them? And which one did you not tell them? So the concerns that they didn't get to share is called unmet needs. They had a need, but they didn't get to talk about it. So that needs are not met. One of the leading cause of healthcare costs skyrocketing, especially in the United States. So this was done in Philadelphia, I believe. And excuse me. And one of the things that we notice is this: what happens in the doctor's room that some patients are more likely to talk so that it reduces their unmet needs. In other cases, they don't. So their unmet needs increase. So then they manipulated the conditions in the room of consultation. In condition number 1, here is how the physicians ended their consultation after about similar duration of time. They said at the end of the consultation, "Is there anything else that you would like to talk about during today's visit?" Condition number 1. Many of you probably say this because it's in your textbook. Condition number 2. Doctors ask the patients, "Is there something else you would like to talk about during today's visit?" Now, when I say this, if you don't know the study, if you already know the study, you hear the difference very clearly. If this is your first time hearing about this study, very likely you might not have heard the difference between condition 1 and condition 2. So if you didn't hear the difference, don't worry, don't panic. It's designed to be like that. Again, I'm going to repeat. Condition 1, doctors concluded their consultation by saying, "Is there anything else you would like to talk about during today's visit?" Condition number 2, they said, "Is there something else that you'd like to talk about during today's visit?" Did you hear the difference? What did you hear? If you heard the difference, please put it in the chat box. Yeah. So for some reason, in the first condition, the doctor said, "Is there anything else?" Second condition, "Is there something else?" Another very well-known study in communication science, but does that make a difference? In which case do you think patients talked more? Imagine you being asked this question: "Is there anything else? Is there something else?" Many of you say something. How come? Why? And when we actually ask why, that's when we have so many different possible answers. Psychologists will give us psychological answers, and linguists will give you linguistic answers. Why? And it comes down to a very simple thing. It's a habit of language, habit of English. So for those of you who speak English really well, you probably don't know, or English you didn't have to learn in school. Well, you actually, it's your native language. You probably don't know why that's the case, but it feels like when you say, "Is there anything else?" you're like, you want to say no, and it's because that's the habit of the language. So linguistically speaking, the any is associated with absence of something. For example, if I want to say, "I don't have idea," and I have to choose either any or some, what would you choose? "I don't have blank idea." Do you use any or some? Any. I don't have any idea. If I want to say, "I have friends," any or some? Some. I have some friends. I have some ideas. I have some money. I don't have any idea. I don't have any money. I don't have any friends. Any is associated with absence. Some is associated with presence. Isn't that amazing? What's amazing is when you hear the word, just half a word, any, we are almost conditioned to say, "No, I don't have anything else." But the minute you hear something like some, you're like all of a sudden, yeah, actually. And then you say something more. Better yet, if the doctor says something like, so what else? How are you doing otherwise? What else? They will tell you something more. Now then, one of the major concerns that a lot of physicians had is like, yeah, but then I don't have the time. What if they start talking again? I only have this amount of time. So in this study and many follow-up studies, they actually did study, does it increase the time? And apparently it doesn't. So if you want to know more about it, please read the case. But here's a question though. By how much do you think you are able to reduce the unmet needs of the patient just by switching out half a word from any to some? In percentages, just take a guess. How many more like percentages of time that patients were more likely to talk? 35%? It sounds like, I feel like an auctioneer going once, yeah. 50%? Okay, what are some other guesses? As a study in medicine, stats tend to be a little bit more conservative, yeah. 60%. Okay, it's going up. Oh wow, soon we're gonna have a winner, I guess. It's like auction, What else? What are some of your guesses? 15%, Heather. Okay. $1. What else? What are some guesses? We just switched out half a word. Anything else? Something else? Many times you don't even hear the difference. 25%. Oh, I hope that you're kind of encouraged to actually know it's not that hard. Jessilyn is like 58%. This is the actual study, and this was done by interprofessional team, which I love. So John Heritage is a sociolinguist, as you can see in their credentials, and we have a medical doctor there as well. So interprofessional study that's done, and it shows 78% of reduction. It does not increase your consultation time. What might care sound like? Isn't this shocking to you? That you can reduce patients' unmet concerns, actual unmet concerns, not only perceived, but actual unmet concerns in primary care. The difference, I would say, a half a word can make is 78%. Hopefully this story is shocking and encouraging because it's not that hard to do. By the way, is this useful to you that I tell you like research stories? Hopefully this is. Is it okay? Yeah? Are you ready for the third study? So study number 3. And study number 3 is the one that I actually found. Oh, by the way, this is study number 2. And all these things, it's there, so you can read it. But study number 3 is when the story really outruns the data. And this was done, actually initial one was done, and then there's a follow-up that shows the mechanism of what might be happening. And then also then after that, there's a commentary actually made by 2 different physicians, and one doctor is from Sunnybrook. And it's an international study that was done in the Netherlands. And what they did was, they gave, in the very first study, actually, it wasn't a real situation. A second study was in the real situation. But in this particular one that I want to tell you about is that physicians were given a case, so a patient case. And the first study shows that exactly the same case, all the same cases and the symptoms and all those things are the same. But one thing was different. One thing was the patient now had a label on a scale of from 1 to 6. So 3 is around like neutral, kind of like labeled as neutral. Scale of 1 to 6, 1 was like labeled as totally dependent, helpless patient, right? And 6 is patient who is aggressive, difficult patient. So in this case, they're given a case. They were not looking at the patient directly, which, the second experiment, they actually did that. So first case was they're given the patient case with all the same things, but then it's labeled as either neutral or, very dependent, submissive, or the patient is labeled as aggressive, very difficult. And when you get a case with a label like that, disruptive patient, do you think it's going to impact the accuracy of your diagnosis? Accuracy of your diagnosis, is that somehow, do you think it impacts how accurately you do? And it's amazing that you say yes, especially if you're sitting down with somebody and this patient becomes increasingly aggressive towards you. Very likely, your diagnosis will be impacted by that. But in the case that you're actually reading the chart, and with a simple label that says the patient is aggressive, very aggressive, okay? Now, let me ask you, by how much? When you tell yourself a story that this patient is very aggressive and difficult, and some cases are not just simple cases, some cases are complex cases, okay? And by how much do you think you might be influenced in your accuracy of diagnosis? Out of 10 cases, how many misdiagnoses do you think is possible? Not you personally, but in general, what do you think might be a rate of misdiagnosis? Out of 10, how many cases? Brittany says 6. Nicole's like 3. I tell patients this story so that, they can actually behave better in the clinics. But according to this study, which is pretty shocking, even in simple cases too, 42%. And you're not sitting with a patient, you're simply reading the chart with this label of very difficult and challenging, and likelihood of that person getting misdiagnosed was up to 42%. It's not up to, it's actually average 42%. And even more so in complex cases, that's almost like 2 in every 5. And this scared me a little bit. And I remember when I was attending my dad's oncologist appointment, I kept on asking questions because I just don't know anything about it. And the person is expert, and I kept on asking questions. And later on, I actually accessed the chart, my dad's clinical report chart. And in that chart, she put in writing, the patient's daughter is challenging, asking stupid questions. I'm not even kidding. It's in the clinical note. I was so upset. So then I said, how can I change this clinical note? Because I have questions. This is my father. I remember telling that doctor, I said, you know what, this might be one of many patients that you have, but this is the only thing that I have. Of course, I'm going to have stupid questions. So I remember challenging her, and she put it in the clinical note. And now I wonder how that report was read when it had a label. Isn't that so scary? So 42% was misdiagnosis. I tell you these studies because it is very interesting to study from communication perspective. So this is what I study. When I hear people tell their story, we've done truly thousands of hours of observations of how people talk, especially in clinical settings. We have colleagues in Norway, colleagues in Victoria who do this particular interaction between physician and patient using microanalysis of face-to-face dialogue. And when we listen to them, very simply put, patients tell us what happened in the past and what might happen in the future. And also they tell us something that they want more in their life and something that they want less in their life. Very simple organization, isn't it? So when you put it like that, we have 4 quadrants starting from the upper right corner. So when people tell you something that they want more in the future, that's quadrant one. And that is called, what would you name this baby? When people tell you something that want in the future, if you know the answer, hold off until other people actually make their guesses. Something that they want in the future. Dimensions here are timeline and preference dimensions. And we're looking at quadrant number one, where people tell you something that they want more of in their future. What would you name this quadrant? Desire, absolutely. Something that they want. Like, hello. Goals and aspirations. Aspiration means different things to me right now as I actually go through languages. Yes. Hope. A wish. And in this particular model, we call it preferred future. It's not a perfect future. It's just a preferred future. Okay. What about number two? People tell you something that happened in their past that they really liked. Experiences, interactions, maybe thoughts, feelings that they really liked that worked for them. It really worked for me. What would you call that? Quadrant two. Preferred past is a very good guess. What else would you call it? Something that happened in their past that really worked. Yeah, I really liked it. Okay, successes, absolutely. Positive memory and experiences. And yeah, this is what we call resourceful past. And the words like resource is influenced by Gassman and Graf, their idea of how do we activate resource or how do we activate problem, especially when patients talk to us. Some of us are very good at activating their problems and leaving them there. But you can do both. You can also collect biomedical information, yes, but also you can collect person-centered information. How do we do that? What about quadrant three? What would you name this quadrant? Things that they tell you that happened that is not necessarily their preference. And it happened in their past and they didn't like it. And right in the middle of it, you're sitting down with the patient, and we call that point zero, by the way, if you use this as a research protocol. So we have a name for that. The now is the session that you and I have in this session, yeah? Nicole, regrets live there. Absolutely, regrets live there. Shame live there. Guilt, they live there. It's a home for all of them called troubled past. And all of us, we have troubled past somewhat. And then the last quadrant four, is when people tell you something that might happen in the future that they're not looking forward to. What would you name it? Oh, fear and worry and dread, they all live there. It's their home because it's called dreaded future. And they all live there. So this is where they live. And these are the names. Anticipatory grief. Oh, Shelley, that's such a philosophical way to look at it. Yeah, we do. And positive psychology will tell you, where is our default zone? All human beings, most human beings, you wake up in the morning in which zone? According to many of their research, our default position, we wake up in mild dread. Hopefully you don't wake up every morning thinking, I can't wait to live out today and get the fullness of the blessing today will bring. I mean, that's a conscious thought, that conscious effort that we make. But our default zone as one of the weakest species having to survive, we have the DNA passed down from our people who were very careful, who worried a lot, and that's how they survived. So we wake up in probably quadrant three and quadrant four on a daily basis. Some days we wake up to quadrant one. but many days on our average 3-to-1 ratio. That's called negativity ratio or Losada ratio. And we wake up to quadrant 3 and 4. And very likely in our narratives that we hear, we are more likely to detect quadrant 3 and 4 in somebody else's narrative, same narrative that you looked at. And you're curious about some parts, but there are some specific parts that we can analyze. For example, there's the dreaded future that they tell you. Pushing against the wall, I'm not sure if I'm still the right person for this. When we could actually do this analysis together, and inter-rater reliability of this analysis is actually up to 97%, average 92%. So all of us probably will rate it similarly. But for the interest of time, I'm going to just show you the analysis. Quadrant 3 information, trouble past of this particular person, is when they talk about lately something changed, meetings, metrics, constant changes. This is not something that they want. It's been happening so far in the past. No time to think. There's no time to connect. Feel like pushing against the wall. Maybe I'm here. I've been here too long. It's quadrant 3. Many times, all of us, we are so good at problem solving. We dive right into this particular information and we're like, yeah, tell me more about this. But what happens is there are also other information in this narrative. For example, resourceful past is right there. I've been doing this work for a long time and I used to feel like I was making real. Some of you actually said, tell me about the impact. Now you're building on the person's resourceful past if you do that. Tell me about the impact. So you like connecting with people, huh? This is how you build on the resourceful past. So, they must have a really good reason to keep you there because you probably are the right person. If I were to ask them, what would they say? What would they say? That, why are they keeping you there? So you can really build on that information. And there's a little bit of quadrant 1 as well here. You can infer that they want to make a real impact. They want to have time to think. And some of you actually talk about this. Some of you say, so what does your good day look like? You can be broad like that, or you can be like, so you want to make a real impact, huh? Suppose you had more time to think. Maybe suppose you get to connect with people the way you used to. What might be different for you? Some of you actually did build on this quadrant 1. Because what happens is, yes, in your job, probably as your job, you need to diagnose. Diagnosis literally means dia means thoroughly or through. Gnosis means to know. And many of you are in the role of thoroughly knowing. And especially now it's more challenging because people have ChatGPT and they come to you and say, I think I have this. But you are the expert of thoroughly knowing. That comes with you asking tons of questions. Because you need to know so that you can make a decision about what are the next steps that you can recommend. But in the same space, there's a dialogic space as well. That's why this is called dialogic orientation. The difference between diagnosis and dialogue is diagnosis tends to reduce it to this one possible thing. So there's a big thing, and you chop it up, and then possibly, maybe this is it. Problem solving, prescribe, treat. Dialogue is there's a topic. You don't chop it down to one thing. You actually grow it. It's almost like if you have a mysterious seed, how do you find out what kind of plant that is? One way of doing that is dissect it and diagnose it. Oh, this was an oak tree. Okay. Oh, interesting. Or another way to find out is plant it and grow it and see what it might be. Dialogue is kind of like that. You grow because you may not know the logic of them doing their life. And I actually included the actual clinical case here that's more of an excerpt from an actual case. But maybe you can actually read that and think about it this way too. So let's say this is an 84-year-old woman. And she just had a little fall. And I'm going to just read it out very quickly and see if you can analyze it using this quadrant. She says, what I really like is to stay in my own apartment and manage on my own. And she actually did talk about she likes cooking her own food, at least enough to get to the corner store and church. And I've bounced back before. This happened before after my knee surgery. I did all the exercises and was walking around the block, walking around the hallway in the condo. But since I slipped in the bathroom last month and couldn't get up, I felt so shaky and ashamed. Now I keep thinking if I fall again, my daughter will move me to a home. And I'm going to lose all this that I have right now. Maybe, because she has a history of her daughter taking away the driver's license. Okay. Now, when you hear a story like this, you have a habit of going straight to biomedical, or you want to just kind of like, okay, problem solve. But kind of like, let's kind of step back a little bit. And there are other information here that you can build on as well. Do you hear that? Some of you really good practitioners, clinicians, you actually do this. You not only hear the biomedical information, yeah, psychological, okay, I get that, but also you hear the resourceful past and their preferred future. What do you hear that they say that belongs to their preferred future? Above the line, what do you hear? And for many of us who are so well trained to problem solve, we miss it, right? We kind of go to like, yeah, so, the slip in the bathroom, tell me more about that. Yes, we need to do that because you need to diagnose. But also, there's tons of other information in there. For example, quadrant 4, what are they dreading? They dread, now I keep thinking if I fall again, my daughter will move me to a home and I'll lose this life that I still enjoy, my autonomy, my control. Quadrant 3, what happened that they didn't like? Since I slipped in the bathroom last month and couldn't get up, this is like a mild trauma or major trauma. And then you hear that? Yeah, Catherine, she wants to get on opportunity to get back to her life back. Yeah, she wants her life back. And probably she's asking for available resources. What can I do? If that's where you're going straight, that's amazing. And she's telling you, resourceful paths. It happened to me before after my knee surgery. I did all the exercises and I was getting better. But in the background of their mind, they're thinking, I'm getting older. I'm not getting any younger. Will I be able to bounce back again? There is that slight dread. You hear that. And then they're telling you, what I really like is stay in my own apartment. And it doesn't have to be in that form. But what can you infer from what they're telling you? What do they want? Managing my own. Maybe they don't know about a resource that they can still manage their own, maybe in a slightly safer environment. Maybe there is something else that we can have in their place. Independence, absolutely, to be more self-sufficient. And at least enough to get to the corner store and church. This was very important to them. So when you listen to what they want, it's not either or. Either you listen to diagnose or you listen to dialogue. It's not that. It's actually both and. When you listen to their preferred future, what their wishes are, what they want, also there's a little clue to how we can actually support the person. So in a clinical setting, it's not cut and dry. Many of you know how to do this already. That's why my mom comes back from that geriatric specialist saying, she treated me like I'm her aunt or something. Like she spent like entire like half an hour. And I was there to advocate for my mom because she doesn't speak English well. And the doctor said, you're doing really well. And she's like, so, if you keep it up, probably I might not be able to see you again. And we were all laughing. And she's like, no, maybe then I'll get sick so that I see you. But it was a joke, but that was such a beautiful encounter that, wow, you actually took the time for my mom. So, whatever she tells my mom to do, I will make sure that I'll follow through. And that's what I'm talking about. It's not an extra thing. It's just one small thing that you can change to make the patient feel heard, seen, and also felt cared for. Isn't that amazing if we can do that? And I want to say the same thing. I don't want to tell you to do more than what you do because you're probably doing enough. And probably many of you think, man, what do I do for my own self-care? I hope that you actually wonder about that. Otherwise, you get sick like me. I didn't think about that actually carefully. And then I was so surprised, why do I have laryngitis out of nowhere? And because I didn't take so much care about me doing all the good work that I do. But then I realized, oh, this is my body telling me, okay, enough, hello. So I really hope that many of you actually think about your own self-care too. Interfluence is interfluence and how we story each other into presence. Because it's data is one thing, but our story does a lot of things. And how we do that is by using multimodal flow of meaning like words, tone, timing, gesture, and all these things. Because you do influence and your patients will influence you. And it's a continual calibration of us becoming in our conversation. And we do that by keep orienting the patient in certain directions. And I think I actually experienced it myself like firsthand. Watching my dad going through his journey of, we didn't expect it at all. And, right now I have this cough, and every time I cough, I think of him because that's what got me to suggest to my dad. He was coughing for a few months and it was getting slightly worse. And I said, listen, you have to go see a doctor. And he said, no, I'm fine. Finally, I convinced him to go see a doctor. And he was diagnosed with a stage 4 lung cancer. And that conversation as a family member, even as a communication scientist who knows how to do this, probably that conversation was the second most difficult conversation I had to have with my dad, especially sitting in that room, especially if you have family members come as a translator. Please be very mindful because I was there as a translator. And I didn't expect to get that diagnosis of stage 4 lung cancer. The doctor told me that in a rather careless manner, flipping through the chart. It's like, oh, by the way, your father has stage 4 lung cancer. And I was like, what? And I remember my dad sitting at the back, tapping on my shoulder and saying, honey, what did she say? That was probably to that date the most difficult situation that I encountered in my entire life. My dad asking me to repeat what the doctor has said. And I had to tell my dad myself that you have stage 4 lung cancer in Korean. And at home that night, we had this conversation. And, my dad had said, I wish I went to see the doctor earlier. And you hear that is a regret, it's a regretful past. And he also said, I don't know how long I have left to live. And that's a dread. And then he said, I wish I have 2 more years. And that's a quadrant 1 that I could build on. And I said, Dad, what would you do with the time that you have? And he told me his wishes for the remaining time. And he wanted to go travel with my mom to visit the graveyard of Mozart, Beethoven, all these things to pay our tribute as a human being. And he actually wanted to come to the lecture that I actually do. And all these things came true. And the highlight of his life, at the end of his life, he said, was coming to the lecture that I did at the Harvard Medical School, where we had 800 people in the audience. And I got to share his story. And I invited them, my parents, to stand up. And they stood up, and the entire room got up to their feet and gave them standing ovation for 3 minutes. And in the last week of my conversation with him, He said that was one of his highlight of his life, that he realized that he really lived a good life. That became his resourceful past at the end of his life. And I remember my mom actually was complaining too. Complaining is a light word. My mom was devastated. And she told him, you said you're going to actually see me go first. You can't go first. And they've been married for, about 49 years at the time. And my mom's like, how can you do this to me? And you said you're going to see me off and you can't do this. And, patients and caregivers, they go through a lot, especially caregivers, primary caregivers. And I remember my dad's response, and he reached out and held my mom's hand. And he said, I know, we said we were going to do that. And thank you so much that now you're walking me home first. And later I realized that he was actually quoting Ram Dass, who says, we are all just walking each other home. And that was one of his last words. And he said, thank you for walking me home. So I want to introduce this idea of when you're sitting down with your people, whoever that might be, just a simple reminder, we're all just walking each other home. Isn't that so beautiful? So I want to end on that note. What do you think?
Dr. Moon, thank you so much. Thank you so much for sharing the science and the research, but also your personal story and grounding all of this work to make it possible for us to do better, both in our practice, in our work, but also in our lives, connecting with the people around us that are so important to us.
And thank you so much for saying that, because as a result of this, coming to this session, if you change the way that you talk to your family members tonight, that's going to make me so happy. And that starts with your immediate family that you love the most. I hope that you do that. Thank you so much for actually saying that.
Thank you. I just want to call on Barry Goldless because he put a comment in the chat about the underlying premise of the comprehensive geriatric assessment. Just wanted you to comment on that, Barry.
I just wanted to say that generally, when we do a consultation, we expand the diagnosis rather than narrowing it down the way it is in classic internal medicine. And part of that is talking to the family, the others. So this just shows us the science behind the approach that I think we've been using or trying to use for many decades in geriatric medicine. So it's wonderful to be validated with this kind of outstanding research.
Yes. Absolutely. That's why this is a perfect audience. Thank you so much for doing actually the work that you do.
Thanks, Haesun. We're at the top of the hour. I know that people just loved this conversation with you, and thank you so much for joining us and delivering the 2025 Rory Fisher Lecture. It's been a pleasure. Thank you so much.
Thank you so much for inviting me. Bye, everyone. Have a better conversation today. Oh,
people loved it. Thank you so much.
Oh, this is so heartwarming, and they were so engaging. Thank you so much for doing this. Oh,
people don't want to leave. It's hard sometimes to connect with people over Zoom, but you just did that beautifully. I think everybody felt the warmth and the emotion of your stories, and thank you so much.
I so sincerely appreciate the work that especially these people do. Like seriously, the work that you do is life-changing for not only for patients, but the patient's family. This is like really life-changing work that you're doing. So I'm so honored to be here, actually. Thank you.
Thank you.
Bye, everyone.
Bye-bye.